Hello, Sir Bill. Hello, Sir Cat.
Hopefully I can get. Okay, there you go.
Sorry about
Should I start again? It's okay. All right. Well, thank you again, everyone. Thank you for having me and watching my lecture. Hopefully, I can give you a better and deeper understanding of one of our favorite hormones, especially in hormone replacement therapy, which is also one of the most misunderstood in relation to its health benefits, which is estrogen. We will discuss this in the view of the urine metabolism test, since there are different ways to assess for estrogen. Others are blood and saliva. I won't be endorsing any companies, but common ones out there are Dutch, Genova, Doctor's Data, which are all similar, basically. And here are my
Dr. Nario, you're a little bit muffled. This sound is it? Can you clean that up a little bit or not?
Hello, is that better?
That's much better. Yeah,
Hello,
that's much better. Yeah.
okay, all right. Should I start again? No, you're good, right? All right, so here are my credentials. Before I start, I just want to thank AOSIM and Dr. Clearfield for his invitation, and also my mentors, Dr. Cora, Dr. Forsyth, Dr. Magic, my bio staff, especially Lucy and Carrie, my left and right arm. What would I do without you guys? Oh, I always want to, I guess, thank my mentors again for teaching me this, and my co-faculty members in HRM, Dr. Fanon, Tara Scott, Sarah Godfrey, and Trindade, who shared their knowledge to me in this special topic. Well, okay, we're sounding like a radio station here, full of shout outs. Now let's move on into our discussion. When I started my career, I I only wanted to see again treat men, right? Why? Because I can relate better. Male dog equals male patient. I was thinking of testosterone therapy, anti-aging, stamina, and muscle building, etc. I only wanted to treat this guy, and yes, even that guy. Suddenly, I realized we have numerous women showing up in my practice who are perimenopausal, menopausal, who has fatigue, moodiness, hot flash. Of course, I cannot reject them. So what do? You adapt to learn how to treat them. My mentors, the fellowship training in HRM, and as I listen to my patients, I enter into the realm of BHRT for women. I'm not going to discuss all hormones involved in BHRT, but we'll discuss the most dynamic one of all, which is estrogen. Well, what is it, different types, and how do we detoxify and regulate them? In BHRT, we all know about the most common hormones involved, which are estrogen, progesterone, testosterone, and cortisol. So excuse me, there will be moments that I will be using these letters to pertain to these specific hormones. And on the most dynamic one of all, at least for me, due to its function in various forms, which is estrogen. Best way to really understand it is to quote the Endocrinology Bible, which every OB guy, I guess Dr. Bill knows about this, knows about, and this is the Spearoff book of clinical gynecologic endocrinology and infertility. As defined here on the slide, estrogen is first in the luteal phase, specifically made on day 1 to 14 for regular cycles. And always remember, day 1 is actual start of bleeding and a consistent flow, leading to a thicker endometrial lining. Next, it's causing growth in the reproductive organs of women, the breast, uterus, ovaries, specifically when we're talking about alpha receptors that are stimulated, leading to proliferation. I'll explain the receptors later as we move forward. And then next would be when estrogen is mentioned, we also need to know progesterone. Progesterone provides balance to estrogen action. Reason why we usually give progesterone during BHRT along with estrogen. And next, usually if estrogen is unopposed, it can lead to reproductive cancer via cancer cell activation. So again, another part of Spearoff book, Estrogen Facts, stimulation of estrogen can occur in both breast and endometrial tissues due to the presence of estrogen receptors. Next, remember, there are 2 types of estrogen receptors, and these are receptor alpha, which is stimulatory, and beta, which is inhibitory. Next would be progesterone is protected due to its inhibitory properties and used in balancing when using estrogen, especially in breast health. Then also, this is nice to know. the last statement here is the statement is questioning if tamoxifen really works. It is used to block the actions of estrogen in premenopausal breast cancer. When you look at this, when estradiol is this strong in relation to the affinity to receptors, how can tamoxifen bind and do properly its work? Makes you think, right? And again, this is another one of the, again, societies that we always hear about in relation to recommendations about hormone therapies. This is what they say about estrogen. So now, first you can tell that they are still deciding on unopposed estrogen prescribing in hormone replacement therapy. We all know that with or without uterus, usually use of estrogen with progesterone always for protection, again, is okay. Vaginal estrogen is okay, but I for myself, I prefer the HEA due to the faster action and just needing to apply it on the outer area of the vagina to be effective. Next, I agree with vaginal estrogen or DHEA for vaginal dryness. Remember, vaginal E can also be used in menopause with recurring UTIs, not only for dyspareunia. Next, when you hear synthetic hormones, part of that is equine, equals horse. We are not horses. We don't run the Kentucky Derby. Reason why it produces too strong of a receptor stimulation. Next would be probably not a good idea also to just use estrogen for long durations without progesterone. They're saying that estrogen use has low risk of breast cancer, might even lead to a lower risk when you use it with progesterone, so even better outcomes. And lastly, hot flash only is indication, the only indication that the FDA approves for hormone therapy use, but many indications which are long-term benefits, such as bone, brain, cardiovascular health, are still currently unacknowledged. Another part in their recommendation, as you can see here, is first with the why is it still unclear that hormone therapy is still questioned in relation to the improvement of quality of life, even in asymptomatic women. Would they be happier if they realized that they are preventing strokes, heart attacks, and even osteoporosis in the future? I would. Next, the use of hormone replacement therapy does increase the risk of CVD and breast cancer. If it is unmonitored use, though, meaning if there is no testing or preventative screening that is being done to assess how they are working in the body. Reason why we as practitioners should be educated to protect our patients and make sure that they are safe to use BHRT even after 10 years, the 10-year window over menopause. And again, all of these statements can be found in the NAM's website. Another society is the Endocrine Society. And again, you will also find all of these in their website in terms of the ones that I highlighted. As seen here, that small estrogen dose intravaginally is allowed and safe and has proven not to be in the systemic circulation to affect breast cancer. Even ongoing treatments or even personal history underlined here, as you can see, very important in patients who need care with these special circumstances. As educated clinicians guided by evidence-based guidelines, we can address our patients' needs. Next, it's a different story for high doses of estrogen intravaginal. Regular dosing that you would see of vaginal E would be initial dose 2 to 4 grams intravaginal once a day for 1 or 2 weeks, then gradually reduce dose by half. The goal here is to restore vaginal mucosa. And even maintenance dose you would see in the range of 1 gram intravaginally 1 to 3 times a week. Anything more can be systemic, thus the worry about estrogen receptor stimulation. Next would be even the WHI, the study that gave hormones a bad rep. Acknowledges the strength of equine hormones and how they can be unpredictable in terms of receptor stimulation. Speaking of the devil, let's just revisit what this study revealed in relation to the reputation it brought to HRT. Highlights here would be the CEE, or MPA, of course, equine estrogen and medroxyprogesterone acetate, horse estrogen and synthetic progesterone, which are non-bioidentical. When you hear this, you know it's trouble brewing. Was used in the CV or cardiovascular complications and breast cancer outcomes, where I guess the only ones heard by everyone in this study to start fear in hormone use. Let's break it down quickly on why it is flawed. First would be the sample age range. What do you expect when your subjects are 63 and above? More cardiovascular risk, more comorbidities. HRT, when started early, is more beneficial, especially in the perimenopausal period. Next would be oral conjugated equine estrogen. We are not horses, I remind you, which leads to stimulation directly of the alpha receptors. And third, synthetic progestin and progestogens were used versus bioidentical progesterone. As we all know, is safer. All of these factors equals, again, a disaster. The Nurses' Health Study, another study, that we can add in our evidence-based weapons to support the use of estrogen safely in your toolbox. NHS, again here, showed evidence against the WHI where estrogen is cardioprotective. Well, WHI showed 7 heart attack incidents in their study. More weapons here for us. 1 and 2, as shown here, oral CEE used is more of a clot former, but not transdermal estrogen. Number 3, benefit of transdermal estrogen is more than CEE in the arousal realm. Arousal, right? And lastly, even the Lancet, prestigious medical journal, chimes in and is rooting for estrogen. The final nail in the coffin, one of the bigger evidence here. This proves that even horse estrogen alone can be less harmful versus the use of synthetic estrogen and progesterone, making our suspect being more of the synthetic progesterone known as progestins or progestogens that can be doing the damage. Am I done? Not yet. One last, even JAMA gives their thumbs up on estrogen in this headline. That is not fear estrogen itself, but fear on how we use it in its metabolism. Use it wisely. Lesson here is it's not about having a sword or a weapon that is the problem. The problem is on how you use it. It can either cut your hands, if you're klutzy, or it can protect you from your enemies if you know how to use it the right way. I don't know who uses a sword nowadays, but you get what I'm saying. Here is the steroidogenic pathway. Looks intimidating, right? You will see on the bottom our target of discussion, only estrogen metabolism. In my opinion, this is another aspect of other than just understanding what E1, E2, and E3 are. You should be worried about how they are metabolized and used inside the body. Let's first define our class of characters here. E3, the good angel, as I always think about it. E2, it's always stuck in the middle, can turn into bad or good. E1, evil, they're always up to no good. I will use a common urine test panel that I use in my practice to understand the pathways of my patients. If interested, you can always ask us, me, Dr. Bill, you know about this. When I started, I thought knowing what E1, E2, E3 was enough for me to manage the HRT and women's health. But as I studied this more, I realized that I was only scratching the surface. This concept of estrogen metabolism is needed for me to give proper and thorough care for my patients. So forms of estrogen, always bear in mind the receptors that gets affected in relation to estrogen function. Alpha promotes, beta inhibits. Here, E1, or estrone as we call it, is usually the bad for me due to the more alpha stimulating properties that it has. It is a weaker type of estrogen with only about 1/5 the binding affinity as E2, which is estradiol. It increases the risk of developing breast cancer, thought to be related to endocrine disruptors, example BPA like sustained fat, which is adipose, and it's also a source of estrone, as shown. Estradiol E2 is ugly, the most potent estrogen. It's stuck in the middle and can turn into bad or good. It has equal receptor stimulation during the reproductive years. It is most prominent due to ovarian function. And lastly, E3 or estriol, which is the good type of estrogen, it's a weak estrogen with tissue selective activity in the lower reproductive tract. So the birth canal and why it's related to pregnancy and why we like this is due to its estrogen receptor beta dominant stimulation. Another good way to understand this process, if you have 2 children and you give them money, you want to know how they will use it. One child will probably go out and party and spend all his money on booze, and one child saved his money in the piggy bank for college. I don't know how much you can save in a piggy bank nowadays. But if you use estrogen and BHRT protocols, if you create more bad estrogens called 4-OHE, I'll explain this a little bit more later, then you do more harm. If you create more good called the 2-OHE, then you're more protective. More about these terms again in a bit. We have now established estrone as a bad estrogen, or SE1. Even called as such, our body still has a good way to save us from its bad effects. So let's talk about the different roads where we will dispose this type of estrogen. As we encounter various external toxins, usually they are fat soluble, they are filtered through the liver. Phase 1 involves cytochrome P450 enzymes in the liver. The tricky part here is phase 2, which is needing to act on these partially processed toxins due to them being reactive or still actively considered toxic. Reasons why phase 2 conjugation reactions should always be made sure to be working after phase 2, as compounds are now safe to be eliminated in water-soluble form. In phase 3 elimination, usually the gut finishes the job. That is why we always refer to in our practices as the word term detox. I'm sure many products we have encountered in our practice claims to detoxify, like herbs, colon cleanses, diuretics. And this is the process that is involved in all of these. This is an overview process on how unused estrogen is primarily metabolized in the liver via phase 1 and phase 2 detoxification and in the gut. We will go through this as we go along with our discussion. Out of all these phase 2 processes important in estrogen metabolism are methylation and glutathione pathways. Always remember the statement on the bottom. And this is again that phase 1, phase 2, phase 3 happens physiologically. And as we treat it clinically, we have to go through 3, 2, 1, which is in reverse. And this is important for us because this shows us how the process happens in our body. And again, when we see it in our patients. So SNPs, what can affect these detox pathways to go wrong? Phase 1 and 2 are influenced by gene structure and alterations. We call them SNPs. These are substitution of single nucleotides at a specific position in the genome, leading to alteration in function of the enzyme. Again, when you have homozygous, that's the worst, meaning 2 are affected and 2 abnormals. And then when you say heterozygous, usually it's 1 abnormal and it's kind of the less affectation. Usually this is more intricate than what I've been telling you in this lecture, but let's establish just for this lecture, the basic knowledge of what it is. Phase 1 detox. So this involves CYP1B1, 1A1, and 3A4. Here's a famous urine metabolite test that I mentioned. And again, this is basically something that we always see in our practices. When we say SNPs in phase 1, the ones encircled here actually is pertaining to upregulation or faster functioning. Right there, those are the circles. And then here, phase 2, methylation, actually there. So phase 2, methylation and glutathione pathways, SNPs, usually encircled, as you can see, leads to downregulation or lower functioning of the enzyme. Emphasis, again, only on estrogen metabolism is methylation and glutathione pathways. As an example here, the SNP here is in the CYP3A4. This leads to more 16-OH. I will explain this again later, what the significance of that. Usually high when there is 16-OH, it's usually high when there is high environmental endocrine disruptors such as BPA or even PCBs. So again, phase 1 related to the CYP450 enzymes, and which is always upregulated in phase 2, related to COMT and glutathione pathways, which is the downregulation. So the CYP1A1 SNP, so let's start with the pathway for the production of good estrogen here, which is the protective pathway. So enzymes involved here in phase 1 is CYP1A1, leading to the production of more 2-OHE1. So 2-OHE1, now let's move forward to, again, giving you a little bit more thorough evidence-based medicine here. So even though it's not methylated yet, already it has good benefits. It has slight protection towards the breast cells, but not enough though. We still need to push it to be methylated to be more protective from 4-OH. Again, you'll understand who this person, who's this entity is, the 4-OH. And as you can understand, 4-OH is not a good type of estrogen to have. The role of methylation here, as 2-OHE1 gets methylated by COMT, the COMT enzyme, it leads to 2-methoxyestrogens, which has now therapeutic use in breast cancer and even cardiovascular disease. This is where we want to be. The COMT enzyme, the COMT gene, remember polymorphisms are associated with reduced enzyme activity. If lowered action of COMT, this will lead to lower production of protective 2-methoxy-OH and more risk for cancer. Later, you will see how 2-methoxy-OH acts as a buffer to prevent 4-OH in doing its damage. Here it depicts the CYP1B1 SNP. But now let's talk about the path that we want to avoid. This is the red line, which means danger. CYP1B1, if upregulated, leads to cancer-forming estrogen. CYP1B1 polymorphisms is associated with faster enzyme activity, leading to increased 4-OH, which is carcinogenic, not only for breast cancer, but also other reproductive cancers, according to this journal. 4-OHE1, this is the bad boy of the show that we need to prevent. So I've been pertaining to this a while ago, and a very potent tissue stimulator, and not only for female reproductive organs, but also for men. Thus, reason to check this also in men. And here, the DNA adduct formed from 4-OH are covalently modified or modifications of the DNA that results from exposure to specific carcinogens and short DNA damage. And thus, the level of DNA adducts in normal cells can serve as a biomarker for a significant exposure to carcinogens. As you wonder where our favorite horsey estrogen does its damage, here it is. Why it's carcinogenic? Because it promotes 4-OH production. Who will save us from this enemy? Nobody else but Super D. D for detox. 2 paths to neutralize 4-OH. Again, methylation and glutathione pathways to divert it away from reaching the DNA. So MTHFR deficiency, you would notice your bigger challenges, again, when I say bigger challenges, it's not activating these paths in relation to the SNPs. If 4-OH is not inactivated by COMT, related to the methylene tetrahydrofolate reductase enzyme responsible for production of 5-MTHF, 4-OHE1 can be oxidized to quinones, compounds that will attack the DNA. What did we say about phase 2 detox SNPs? Always downregulated. Worst SNP is the C677, milder defect is the A12. We can see how it contributes to cancer even with a milder defect, which is the homozygous, as I mentioned, is worse. Thus, we should be checking. This can initially be ordered in a regular lab test. So GST, the other arm, is the glutathione pathway. If you do a genetic test, a specialized test, these are the results that you will see. Absent more aggressive replacement and supplementation of the glutathione to help detoxify. If present, we still want to be supportive. If you think about it, it is good to have a CYP1A1 SNP, so it can just supply the body with protective estrogen, right? But that's not really good, of course. Now understanding both 2-OH paths and 4-OH paths on how they work, we can now understand CYP1A1 better. Remember, if there is a phase 1 SNP, it will be upregulated. Increased 2-OHE1, still unmethylated and not ideal for cancer protection because we want it to be methylated. Reason why we need more of the methylated
version to protect us from the 4-OH load. This is how CYP1A1 SNPs contribute to the worsening condition of an increasing 4-OH load. So not forgetting 16-OH, on literature, it's still considered an estrogen receptor stimulator, though not as strong as 4-OHE1, but I still consider it to be worth lowering down. Special mention about our endocrine disruptors that can modify intracellular communication and function, found in our favorite detergents, perfumes, plastic bottles, cleaning agents, pathologies, are actually produced mostly affecting phase 1. They affect hormonal balance, metabolic, and cancer activity. When all else fails and you don't understand this part of the lecture because of all the medical jargon that I just spelled out, look at this colorful pie graph in the corner of the test sheet. And that shows a summary. The main objective here is to put all of these numbers in the normal ranges for a proper estrogen metabolism process to occur for the patient. As we move on, to remind us where we are in the process, we just discussed phase 1 and 2 and how estrogen gets metabolized. And now let's go to phase 3. Always remember, I cannot overly emphasize, I'm knocking in the door of your frontal cortex here. Let me in with this message, okay? Physiologically, it happens phase 1 to 3. And when you treat this, you always want to do it in reverse, which is 3, 2, and 1. So elimination, the gut is the factory that will package estrogen for us. And it goes out again through that aspect and not accumulate in the system and to be disposed of properly. So we have to have good gut workers to do this. We need biome, a good microbiome, and less inflammation, all in combination. We have tons of workers in our gut. We have good and bad workers, rich diversity, and they have groups like unions and circles of friends, which are called the phyla. Not only are they doing one thing, they're always known for digestion, but multitaskers, as mentioned above, to prove that they are multisystemic in function. Reasons why we need to make sure that they're always happy. So this is a famous stool test that I'm sure everybody's kind of familiar with. And here is the party that is going on in the gut to give you an idea. A sample of a common stool test that we do to assess the microbiome diversity. So let's be specific now about the part of the microbiome that deals with the body's circulating estrogen, which is called the estrobolome. They distribute estrogen in the body for its systemic effects. Lifetime exposure to estrogen causes greater microbial damage. Thus, they regulate just the right amount that the body needs. If we have the right balance in the estrobolome, it was seen that its capacity in hormone regulation can be comparable to a prepubescent microbiome. Again, complete, with higher short-chain fatty acid production, and also more food for your enterocytes and microbiome. Overall, happy gut equals happy hormones. So the specific disruptions that we have, as you can see here, first, the mouth of the baby passes through the vaginal canal, inoculating it with vaginal flora. Next, breast milk microbiome, again, inoculated by the baby's gut. And then Lyme patients, this is a good example for the next one, who are given multiple and chronic antibiotics. They're like nuclear bombs in the gut to create destruction. And then next would be chronic stress that can lead to sympathetic response, which leads to lower blood flow, leading to constipation, for example, and also thus lower blood supply for the microbiome. Next, even inhaled steroids, unfortunately, can disrupt the microbiome. And next would be the one that we always kind of preach about, gluten and dairy, are common allergen sources that we should also avoid. And we always hear about the standard American diet. Of course, sad, frowny face, right? People think we always need more proteins. People want meat, like for that muscle, but instead, in recent studies, we are, the Americans here in our country are lacking more in the daily fiber intake. So that's why the next recommendation is our diets lack in color. Fries and burgers, they don't bring color, just to give everybody a heads up. Next would be, unless pushing the remote and putting chips in your mouth is exercise, then majority of the population are all fit. Again, we need movement. And next would be circadian rhythm disruption. And eating foreign food through travels leads to many gut reactions. And here, mold, again, being trained in the shoemaker protocol, low MSH, which is melanocyte stimulating hormone, is actually destroying the gut barrier. And lastly, poor sleep. This sheds gut lining and less microbiome diversity will be produced. Right, so this is the phenomena everyone is describing leaky gut. As the barrier is broken, now foreign substances can now get into the circulation to create inflammation. These two above are the major effects in estrogen metabolism. In general, intestinal permeability leads to systemic inflammation, leads to suppression of ovarian hormone production, and growth of unwanted bacteria to increase unconjugated estrogens back into the circulation. So UDP, glucuronosyltransferases. Okay, let's just stick with UGT. That's kind of hard for me to pronounce. And enzymes binds to drugs, xenobiotics, and even estrogens. So they play an important part in phase 2 detoxification, then connects to phase 3 detoxification. Thus, toxins and hormones are bound to glucuronic acid, turning it into water soluble. This mechanism that is protective for the body, and after liver processing, will be delivered to the gut, where it may interact with the enzyme called beta-glucuronidase. So here you would see, again, phase 3, I guess, starts when estrogen is transported to the gut. So you would see here estrogen bound to the UDP actually is ready for excretion. But when you have bad dysbiotic gut or bad microbiome or bacteria, you would notice that they can secrete beta-glucuronidase. And in this event, you would notice that instead of the estrogen being excreted or exiting through the colon, it will now be recirculated back into the bloodstream. So thus, we will have, again, higher bad estrogens when you have higher levels of beta-glucuronidase. And this can be tested as well through this famous test that we do. And here is a common stool test that I was pertaining to. A way to do that is, again, a stool sample, and high levels are not desirable due to the correlation of higher recirculating estrogen. Lower levels, not much to be worried about. But look at here, look at the symptoms of elevated beta-glucuronidase. What do they all look like? So you can see it's basically similar to estrogen dominance, right? So they're basically the same symptomatology. So when you treat estrogen dominance, you know you're also addressing the elevated beta-glucuronidase. So time to treat. And again, in reverse, remember that I always remind you during this whole lecture, I'm beating it to you like a drum in your head. Physiologically, it occurs through 1, 2, and 3, but it should be addressed in reverse order, 3, 2, and 1. Phase 3, rebalancing the microbiome. The main goals here is to, of course, move that gut, normalize, again, beta-glucuronidase. And we do this, again, with fiber. There's a lot of fiber support out there that helps a healthy microbial balance. Here's the proper distribution. As you can see, soluble fiber, fiber that dissolves in water and forms a gel-like substance, which leads to slowing down of digestion and promotion of absorption. Examples of this would be lentils, nuts, oats, and certain fruits and vegetables. And insoluble fiber, meaning fiber that does not dissolve in water, help food move through the digestive system at a quicker rate. Does not dissolve, it adds more bulk to the stool and leads to a laxative effect. So that's good for constipation. Again, examples would be vegetables and whole grains. And lignans, I'm sure you probably are familiar with that term, or if not. It's actually the structural material in the support tissues of most plants. Lignans are particularly important in the formation of cell walls. We need more color in our food. Thus, these are the phytonutrients and antioxidants. And we eat according, again, to the color of the rainbow. So we always need to add spices to this food that we eat, like curcumin. Even though with poor bioavailability, it still promotes diversity in the microbiome when it's in the gut. It's not dependent on that going through the bloodstream. And here, FDA notes milk. FDA, to remember that term, notes milk, wheat, and soy as top allergens, meaning gut inflammation, and should be avoided. And also probiotics are promoted, like Acidophilus, Bifidobacterium, and known for beta-glucuronidase deactivation for healthy estrogen metabolism. So rebalancing is something that we always need to strive for. And again, disrupted circadian rhythms in turn disrupts the microbiome and also the hormones that we create. So for exercise, 20 to 30 minutes per day at least to increase heart rate and sweating. Exercise has shown to increase beta rate and produce pro-inflammatory and reduce pro-inflammatory cytokines and oxidative stress in the gut. For our supplements, and we always hear about this during the COVID pandemic, vitamin D, zinc, vitamin C, quercetin, healthy immune response keeps inflammation down and supports hormone production. And other supplements such as choline, B6, folic acid, B12 to promote biosynthesis and efficiently bundle toxins up in estrogen metabolites for removal from the body via the gut. And as we all know, stress, lessen the stress effects on our bodies. Constant fight, flight, or freeze quickly disrupts the microbiome. For phase 2 methylation, you would see here that, again, there are actually different things that we can do to support methylation. Methylation, maintaining SAMe, for example, availability will encourage the COMT activity. And methionine, especially important here, is to lower down homocysteine. That also can be a function of methionine. And here is our usual supplement supporting cast for methylation. I'm sure everybody knows about this, but I want to emphasize the ones that we kind of forget most of, like TMG, the tetramethylglycine, and also magnesium. But the other ones, we always correlate that with the COMT supports. And then glutathione detoxification. So you would see here also the supports for our glutathione. And I'm just going to mention the dosing as I read through it. So for the reduced glutathione, which is a direct glutathione replacement, is 3 grams per day. For ANAC, which is glutathione precursor, 600 to 3,000 milligrams per day. Alpha lipoic acid would be around 200 to 1,000 milligrams per day. Whey protein concentrate, around 2 to 3 servings per day. Magnesium, 400 milligrams minimum. Vitamin C, 500 milligrams minimum again, you can go higher. Vitamin E, 400 international units. Silymarin, 400 to 1,200 milligrams per day. Methylphenic acid, 500 to 1,000 milligrams per day. And SAMe, 400 to 800 milligrams per day. But again, caution about this because with SAMe, it can cause brain stimulation at the beginning of usage. And again, the precursors of our glutathione, the 3 basic amino acids of glutamate, lysine, and cysteine. Phase 1, again, modulators of the CYP450 enzymes. So purple grapes with resveratrol. I know Dr. Bill likes this and wrote a good article about that. And it blocks dioxin induction via the aryl hydrocarbon receptor. And also berries, EGCG also in green tea. So here's the home run clinical pro. In my years of practice, I've always have thought that giving DIM or I3C in a hormonally imbalanced female is beneficial, thinking that it's fixing all the metabolism issues that there is, until I got taught by my mentors about it, that it can be a double-edged sword. So if you have to pick one lesson up in my lecture out of all the information overload that I gave is this: don't start all hormonal female cases with DIM or I3C without checking metabolism. How can it hurt? As the literature above states, I3C or DIM can increase CYP1B1 activity. As it pushes the red arrow further down 4-OH, it will accelerate the formation of bad 4-OH, especially if your glutathione and methylation detox pathways are not fixed to divert it away from creating more of it. This is the reason why fix phase 2 first, then phase 1 should be done before giving DIM. And then don't forget about phase 3, 3-2-1, as I always say. And indications of this type of testing, meaning the estrogen metabolism test. A few reasons why I assess this in my patients, and I'm sure there are more, but this is more in my clinical experience. I use it on women with adenomyosis, endometriosis, even ovarian cysts, fibroids. Well, question in my head is, why are they forming these pathologies? Are there pathologies in the estrogen usage that we need to uncover? Data shows that there are phase 1 and phase 2 abnormalities that are involved in these specific issues. Another indication is for patients who are on hormone therapy. If they are using the hormones the right way, patients with high risk possibilities of developing breast cancer, such as an example would be positive BRCA. People who develop breast lumps, cysts, and even fibrocystic findings on scans. Chance of malignancy transformation or development can all be considered in these cases. I mean, there will be a debate out there in relation to saliva and urine, but again, depends on the practitioner, and also, as we all know, there are plus and minuses in relation to the differences of such testing that can be discussed in another session. And even while on BHRT, if you just want to see how the estrogen dosing is causing bad stimulation, again, saliva or urine can kind of chime in there in that specific example. Well, the most important in my patients currently, because I also work in the cancer center, are post-breast cancer interventions, meaning the ones who underwent chemotherapy, surgery, or even radiation. The mentioned management are good in removing the symptom of cancer. And to follow up the estrogen tests, follow it up with estrogen testing, metabolism testing will now look for the root cause that caused this in the body in the first place. Surprise, men too. But wait, we're not done yet. When we thought women are the only ones who can benefit from this test, we are wrong, men as well. We usually point our finger on testosterone to be responsible for prostate cancer growth. This is evidenced, again, by, of course, using Lupron to diminish testosterone because it's an agonist, GnRH agonist, to lower testosterone in prostate cancer. Dr. Morgan Teller, or even Dr. Clearfield, had lectured about this, backs up the theory that testosterone is not the culprit to aggravate prostate cancer to justify this test. There is now also evidence that a high 4-OH activity or pathway contributes to the promotion of prostate cancer, as seen, as cited here. So men, beware. I want to dedicate this lecture to my father, who's also a doctor, Benjamin, who inspired me to be a physician and to be a man for others. He just recently passed and is now with the angels in heaven. I miss you every day, Dad. Thank you so much for everything, and I love you. Questions, comments, and feedback, please contact me with all my heart and gratitude. I want to thank all of you for taking the time learning from my lecture, and hopefully I have given the gift of education to you in helping your patients achieve better health. Thank you, and God bless.
Wow. Thank you. That's great. That was great. Thank you, Dr. Nario. So,
thank you.
There's a question here. What kind of contraindications for detoxification?
So for detoxification, usually in relation to assessing, I do basic blood tests first. For sure, you want to assess liver functions, kidney functions, and then also, I don't know if you have encountered this before, sensitive patients. I have patients who've been doing simple detoxifying supplements, for example, and they would just react like a simple milk thistle. I would notice this. Again, there's probably some underlying pathologies there, like mold, illness, Lyme. And these ones you'll just learn as you move forward when you handle these patients. So be slow on these detoxification processes. But again, be guided by your clinical evidences and also your, I guess, assessment on the patient.
Okay. Anybody else have any comments or questions? Prayers for your dad. Is,
Oh, thank you.
is cleaning up constipation enough for phase 3?
Well, you have to remember phase 3 is not just bowel movements. You have to understand if there's dysbiosis also. And again, let me just name the test, Genova stool test. You would see that the problem of gut is not only about moving the bowels. You would see inflammation, you would be seeing enzyme deficiencies, and even dysbiosis, parasites, and protozoa. So there's so many things to assess that. But again, the clinician has to find that.
Can I ask a question?
Yes.
So we use a product called salvesterols, which activate they're a prodrug, and they activate through the CYP1B1 pathway. Can you speak to that pathway? Because you were talking about that on the estrogen metabolism.
Oh, yes. So, I mean, in regards to specifically the salvestrol, or you just basically more of the pathway?
Both. So,
Oh, both.
yeah.
Okay. All right. Well, with the one, so that, again, you're the one that salvestrol, I use that a lot in cancer. But again, that's the more potent form, I think, related to resveratrol. Correct me if I'm wrong on that one. But again, for this CYP1B1, when we use resveratrol there, it's also something that actually negates the actual pathway of CYP1B1. So I just want to remind the audience, CYP1B1 leads to the 4OHE1, which is the one that destroys or creates DNA adducts. When you use directly resveratrol, it actually has a direct effect of moving the pathway away towards going to the good pathway, which is the CYP1A1. So resveratrol does that. It diverts that directly. So it's not acting on the glutathione pathways or methylation pathways, but it actually is something that can be, if you think about it, I have used it directly when I see CYP1B1 abnormalities on my urine testing, thus lowering the chances of cancer production. I don't know if that's something that can be used in animals too. Do you do hormone testing in animals?
We haven't been, but I'm really curious about doing it.
Yeah, it might be
Really see a
related.
ton of cancer. Yeah, I'll reach out to you. Yeah.
Sure.
Thank you.
You're welcome.
What dose of the resveratrol are you talking about?
Is it salvestrol or just plain old resveratrol?
Plain old resveratrol.
Okay, so the ones that I use are the ones that everybody does. I mean, it could be like 500 to 1,000 milligrams a day. So on my end, I always go low and slow. I don't want to go high on my dosing, because again, you would notice that this test will add other supplements to it, not only just focusing on estrogen metabolism. I'm speaking about the whole analysis of the urine test, because you will see here testosterone, progesterone. So on top of that, you're also going to see hormone deficiencies. So for me, I start with lower doses on the other, because again, I promote more food. So, but you won't go wrong with just going low and slow.
Mm-hmm. Okay, great. John, got anything for us?
No, I'm just proud of all you guys and happy to hear what's going on.
Mm-hmm.
And by the way, I missed a little bit because I had to step out. Is Dr. Forsyth still practicing?
Yes, I actually am one of his physicians there.
Wow.
He's how old is he now? Was he 88?
86, turning 87. Don't quote me on that, but I know he's I don't want to make him older.
Yeah.
Quite a guy. And I don't know if MElvin knows about oh God, Brody. Did he ever
Yes.
deal with Brody protocols?
Yes. So the Brody protocol is actually something that's there's similarities in what he's doing. But Dr. Brody is I think the original integrative oncologist here.
Yeah,
in Reno.
yeah, the president of our AOSIM or AOSRD organization here, the past president was Tom Nagley, and he worked with Brody for years. And he wrote what's called the Brody protocols, put it all in a book, and he gave it away free. Did you ever get that, Bill? Do you ever get that book?
I never got it, no.
Okay.
remember seeing it. I was at Nagley's well, so-called office. I don't know if you've ever been there. And I saw it on a shelf, and it was, I think it was handwritten, actually, the
He
copy.
he put it in a PDF, he put it on the internet, but all of those protocols were openly given for free. So again, Brody and Forsyth are two of my biggest heroes in the world.
Yeah, so, yeah, but I don't know, Melvin, do you have that, a copy of that anywhere?
I'll ask Dr. Forsyth if it's in his treasure chest.
See if he's got any, because it's kind of like a lost, it's like the lost treasure of the Sierra Madre or something there, so.
I will do seeking too, and just to share that.
Lots
I
of
have a
kudos, yes, go ahead.
Yeah, I have another question, just because homeopathy here in West Virginia, and I'm only 2 hours away from Washington, DC, and I can assure you that the FDA is rather monstrous in their aggressive fight against homeopathy. I think it's wonderful you guys out west are standing up for this, but how much resistance do you think there's going to be? Because by the way, did you say you went to the British School of Homeopathy?
Mhm.
So you may also be, I don't know if you're familiar with Anton Jayasuriya.
Oh, no, I'm not.
Okay, he was Queen Elizabeth's personal physician in
Oh,
homeopathy.
yeah, okay. Now you remind me.
Yeah, and he's written God, he's written like 90 books. He died a couple of years ago when the tsunami hit.
Mm-hmm.
But
Right.
anyway, I just found out his Queen Elizabeth connection. So I'm supposed to write a book called Homeopuncture. Anton, who treated the Queen, wrote a book, developed homeopuncture, how to combine homeopathy with acupuncture. And I didn't know if you dealt with that at all.
Yes. So one of my mentors, Dr. Cora Ibarra, and Dr. Bill met Dr. Cora, does specialize in that. And that's something that, again, it's one of the older techniques of acupuncture and homeopathy combined together. And I have seen these techniques, her practicing that in actuality.
Now, we use it every day in West Virginia. And when you do the homeopuncture, are you dipping the needles in homeopathic solution?
She does, yeah, she does that. I have
Okay,
noticed.
I found a shortcut that cuts down the time from an hour to 5 minutes. And that's doing transdermal homeopathy. So no, it's everything you're talking about, but it's done with transdermal drivers. So it
Mhm.
takes about 2 to 5 minutes to do a complete treatment that way, where it would take an hour to do it dipping the needles. And it works. That's the good
Wow.
news, because we've been doing it for a while and it does work. It's simple and it's safe. You don't have to penetrate the skin. So what I would like to do is see an 8-year-old treat grandma and grandma treat an 8-year-old, and not require somebody licensed in surgery like yourself in order to do the homeopuncture. Perhaps we could find another way of doing it. But I'm very nervous in what I'm doing, simply because the FDA here is like terribly, terribly against it. And when we try to order the products, we're getting notifications that we are breaking the law and you can't do this and you're committing a felony just because we try to use homeopathy. And I suppose, and Bill too has used Heal products.
Yes, we use Heal.
So the Heal injectable products is what I use because it's high quality, right?
Right, in Germany.
Not allowed in the country anymore. They've been blocked by our government.
Well, yeah, there are different ways on how, again, I think some of the practitioners in our lectures mentioned this, that you let your patients order it for you, and then they can bring it to you to your practice. Because here we do procedures with those, so many procedures with it. But again, this is something that patients bring to us. That's one way on how you can probably wiggle your way through it.
If it's okay with you, I'll speak to you more specifically about that, where to get it, how,
We're
what's
not
legal.
advocating doing anything illegal, just to be clear.
No. That's why I want to know the rules. I love homeopathy. It's a miracle from God. And if you combine it with acupuncture, it's astounding the benefits you can get. And so just want to be able to do it and continue the kind of work you're doing.
Well, John, thank you for mentioning that, because being part of the homeopathic board here in Nevada, that's something that I definitely want to promote, because I've been a member of of this board, homeopathic board, for almost 6 years now. And this is the one that protects us here in Nevada in relation to integrative practices. So, and that's why, as I promote this and speak to other practitioners out there, I mean, I'm not only pertaining to Nevada, because even for other practitioners outside the state, we are helping in relation to this, especially in relation to legal, I guess, attacks, if I may use that word, of the board, the medical board that they're in. Because we have cases here in Nevada that we have protected these practitioners because, for example, chelation therapy. How can the DO or the MD board really advocate for that? So we have saved these practitioners from I guess, legalities. And then the ending of that story would be the DO board, MD board would pass it off to us, the homeopathic board, to deal with these cases. And if this has been proven that these are safe therapies that we approve of, then of course it will fall into your favor. That's why every clinician out there, as being one of the possible board members of the upcoming board now, I would promote everyone to look into this for your own protection. And again, Reno is such a rich state, and that's not only that, but Nevada is a rich state to practice integrative medicine. So this is something that we're focusing on, and we're now inviting naturopaths in here, and then DOs like Dr. Bill, to make the community bigger, because this is just a powerful tool that I saw myself being part of, and now being one of the advocates for it, being a possible board member.
Thank you. I'll be in touch. Thank you.
Yes.
If I may chime in real quick, we have Dr. Aaron Wolf, and Dr. Aaron Wolf is a homeopathic medical physician who was trained in Greece, Israel, and India. And he's looking into harmonizing his needles through radio frequencies. I kid you not. That's the second clinic that Dr. Clearfield's involved in down south. And Dr. Nario, you know about it. And hopefully something like this can, take heed and go forth. And I hope it's something that will work big time, because we need it in this country and we know it. Electromagnetic frequencies, electromagnetic radiation, blah, 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 all the above. If you tie that into the acupuncture, and I've seen Dr. Clearfield do acupuncture with needles, with aluminum foil, with Vaseline. I kid you not. No kidding. Old fashioned, old school. I wish I would have videotaped it. I missed it. Missed that.
We can do it tomorrow, but it's ultrasound. It's actually ultrasound gel. It's not Vaseline.
Oh, okay. Well, half a dozen, one the other. I'm just saying, love all of you. Thank you for what you do. Great class, Doc. Both of you.
Yeah, it's for burns, by the way. So you had a question here, Joe. Your number on go-to supplements.
What would be your number one supplement, Dr. Nario?
For this topic?
No, for every topic.
Oh, for every topic. I like one that
besides a multivitamin.
Right. I like my fish oil. I think I spoke to you about that, the SPMs also, though fish oil is just anti-inflammatory, cardiovascular. I mean, brain health, it's just you have so many weapons with just using a good quality fish oil. And people, when I talk to my patients about it, I'll just get one from Costco. Really, that does not kind of fit the bill. And they tell me I'm burping with it, I'm bloated afterwards. So you really have to find a good one. And that's always a must have for all my patients as part of their arsenal.
What do you think about cod oil? Nordics Naturals?
Yeah, they're also good. Yeah, the cod oil are good. The thing there is, I base this really more. I have a lot of cardiovascular patients on studies. Really, the omega fish oils are higher in terms of the cardiovascular benefits, maybe even over cod oil and krill oil. So again, one of my mentors here would be Dr. Mark Houston. who showed me all the benefits in cardiovascular studies in relation to just using good omega 3s.
Thank you.
It sounds like you're preaching for Dr. Pam Smith. Is she another one of your mentors?
Well, yeah, well, as being a junior faculty of A4M, these are faculties that I interact mostly in regards to these issues. But again, teaching the women's hormones classes, I do interact with them a lot.
Yeah, because Dr. Pam Smith's number one, if you only can take one thing, is fish oil.
Well, right. I agree with her.
So Joel inadvertently did ask you a question. So what are your number one supplements for this topic?
Oh, okay. So for this topic, before I probably discovered about DIM and I3C, that's always, as I tell you, I'm giving all my patients before this finding of mine, DIM and I3C, thinking that it's the magic pill just to fix their hormones. But now I really go more for glutathione, for example, as you can see. So fixing that phase 2 is always that I want to focus on, like even methylated Bs and glutathione probably would be my first go-tos here. Just because, as you can see, the importance of that before going to DIM and I3C.
Are there any lab studies that you rely on to sort of guide you?
Yeah, so the thing here is with the urine test, it's very expensive. Not all of our patients can afford this. So that's why I also still rely on LabCorp and Quest for blood testing. Again, I'm basically preaching to the choir here. You probably know how expensive this test is. And again, as I see your methods as also, and I agree with that, because you can still manage hormones even without these specialty tests. And again, this is a disservice for our patients who are, if we are only basing our therapies, if they can do these very expensive tests. But by lab testing, there will also be parameters like what you do, LH, FSH, progesterone, estradiol, but making sure that it's all LCMS, and also even free and total testosterone. So pregnenolone, prolactin. So all of these are very useful, and I use them a lot as well in my practice.
Yeah, well, I got, as I've said many times here, you know, I've got used to doing the serum test because the DO board here doesn't like saliva and urine tests. They say it's not accurate, and if you're not doing blood tests, you're not doing any. So
Right.
I got pretty. I think I got pretty comfortable with the serum test. Although on occasion we'll do the others. They are expensive. I think the urine tests are $300 to $500. You know, in that range, and you know, no insurance is going to pay for that. It's tough to ask somebody to do that 3-4 times a year, just for the, you know, for the lab tests. We have a serum, we have a generic lab where we can get everything done for less than $300. You know, pretty much everything that we need, you know, all 10 hormones that we measured. So that's usually pretty acceptable. And then we can do just the bare basics for about 125. Okay.
If I may, Doc, real quick, Dr. Nario has been cross-training with Dr. Clearfield, and it's a synonymous like team that I've never seen. It's really powerful, and I'm super honored that you two have, you know, got together and are doing what you do.
Yeah, so Dr. Nario comes to my office and we look over whatever the patient's got going on, and he decides what he's going to do, and I decide what I'm going to do, and then we arm wrestle for it. And whoever wins, that's what we do. That's what we do. Right?
It's awesome.
Nobody gets hurt. Nobody gets hurt.
Amen.
Right. What about things like broccoli extracts? And you know, we've heard about those things all along. As far as, you know, estrogen, you know, boosters, things like that.
Right, and those are falling into the cruciferous vegetables, again, the DIM I3C. So these are the ones, again, that I would use later on after I fix 3 and 2, phase 3 and 2. But again, there is a place for them, and I've seen that before.
Then, okay, so here's the next question. What do you do with those that, you know, especially the postmenopausal females who have thyroid issues where the cruciferous vegetables are actually harmful to. And when
So,
it's kind of stuck.
right. So this is where we put our integrative practitioner hat on. We all know that hormones cannot work well with a dysfunctional adrenal gland and also a dysfunctional thyroid. So as we assess the patient as a holistic individual, we need to really do our due diligence to assess all of these organs in relation to just not focusing on one thing. And I have seen practitioners just fix hormones. They're scratching their heads. They can't fix it for some reason, because they are not addressing these other organs as well. So that's where the thyroid and also the adrenals comes into play.
Yeah. So we routinely, measure 10 hormones. I guess you do the same, right? So, okay. So we do estrogen, and there's 3 estrogens, right? And then we do progesterone and testosterone free and total. And we also do sex hormone binding globulin. And we have our formula to figure out the free androgen index, and then growth hormone, insulin, cortisol, and then DHEA, pregnenolone, and prolactin. That's kind of our routine. I think that's all 10. Right? Did I miss one?
This is Dr. Patel for Dr.
Yes.
Nario. What would you do in patients, those who have cancer, breast cancer, and treated with the surgery, chemo, and don't want any or intolerance to tamoxifen or something or other binder? You said you would give the phase 1 and 2, but so would you treat them with glutathione?
Oh, because are you talking about the possible SNPs that can
Stem cell, yeah.
that can aggravate these cancers? Yeah, so there is a starting literature here, and I spoke to Dr. Patel, Nayan Patel of Oro, the one who makes
Right.
Oro. So
Right.
he does say that there are some cautionary measures about this. So that's why in that, when I recently found that out, but before I really didn't consider that in relation to giving glutathione. But now I feel, I'm very cautious about glutathione with these breast cancer patients. Not only that, but also other reproductive women, hormonal reproductive cancers that they have. So you're right. I do agree with that. Be cautious about the glutathione. And also in the cancer center, when we give our IPTs there, we use glutathione in patients, but we are very cautious now with these female reproductive organ cancers that we use it on.
What did you mention that in IPT you give glutathione to them?
Yes. So in the process that we do in the cancer center, we give IPT, and then we also have days for them to what we call immune boosting. So these are days of non-chemo days. And this is where we give antioxidants, we give vitamins and nutrients, vitamin C, just to lift their immune system up from the previous day of chemotherapy. So, and now because of this new literature, this is something that we're now being more cautious about before we're giving it to everybody as part of that antioxidant day, so that we can lower down the oxidative, process that occurred when we gave our low-dose chemotherapies. So, but now you're right. That is something that was brought up in our protocols.
So would you agree that before you start any biologic hormone replacement therapy, you would put them on probiotics and whatever is required for the gut health before you move to, and what would you move to? You said you would move to glutathione, but then there are also glutathione promoters that you can use, which would increase the glutathione level, but not to the point that you are cleaving the glutathione itself. And then you would use the I3C, and you would use
And then,
probably a DIM or something like that.
yeah. So in that sequence, it's I use them maybe later during the process of fixing the hormones. But yeah,
So
for
it may be a good idea to give the resveratrol, curcumin, something like that, and NAC. So it may work in a different way of reducing the inflammation.
Right, so if that's,
fibrosis,
yeah,
whatever.
that's correct. So if that's your objective in relation to just antioxidant, anti-inflammatory, and this is a patient, again, not considering their cancer status, or if they're not having cancer issues, yes, NAC definitely can be considered there. And everything that you mentioned, you're not going to lose that because you're fixing the gut. Even curcumin, NAC, and probiotics already is addressing phase 3.
Have you found that the patients are sensitive to estrogen and progesterone at times?
Yes, I have. And I have even patients who I start just on progesterone because there are patients who are afraid of using estrogen still. And I just decide to do progesterone on them. And even progesterone with the slight use of that produces hot flashes, or they would notice that their skin becomes more reactive to specific agents. So in this situation, what I do is I just stop and I do focus more on the detoxification process. And then I do have success about reintroducing these hormones again when I suddenly fix all of these different phases that I just mentioned. But you are correct, even just a simple progesterone, you can produce some
And-
reactions to it.
And in case that after doing everything, if they are unable to tolerate either the estrogen or progesterone, you can do the intradermal skin testing for those items, and you can get the neutralizing dose, treat them with that, and introduce the hormones again, and they're able to tolerate.
Right, yeah, that is a good strategy.
And sometimes it's the delivery system that's an issue. And sometimes it's, again, like you said, so sometimes you do get a sort of a paradox and you get progesterone causing hot flashes and night sweats. That does happen in a small, it's actually in the literature at about 4% of patients. So I go to I'll throw my 2 cents in. So there's a product called Relazin by Bonafide. It's made from Swedish bee pollen, and it really mimics estrogen. It really covers the estrogen deficient symptoms. It has no hormones in it at all. Unfortunately, the only way to get it now is you have to get it online, and it is relatively expensive. It's about $70 a month, but it does work quite nicely. It takes care of hot flashes, night sweats pretty quickly, like within a week. It does keep them away, and it's not a hormone. So
What's the name?
it's called Relazin, Relizen, made by a company called Bonafide, Bonafide. So they have Relazin, which actually mimics estrogen, and then they have another one called Serenol, Seranol, Serenol, which actually mimics progesterone, and it's made from a Swedish bee pollen, and they are quite effective. So that's just another outlet, another way to go.
One thing that I also discovered in patients who are experiencing hot flashes, because majority of the explanations would be, oh, it's just estrogen you're lacking and you just give it out of the blue. Any time of the day, every day. That's what we always think about. Another one that I discovered also are adrenal issues. So that's definitely something that I would check if a patient is having hot flashes as well. Because you would also see this in the younger population, meaning reproductive females, who are basically, of course, not estrogen deficient yet. But when you look at their cortisol levels, that's definitely abnormal. That can be fixed, and thus relieving their hot flashes.
And I'll throw in one more for you too. So testosterone actually has been found to cover estrogen deficient symptoms. It takes a little bit of time. It takes about 3 to 6 months, but adequate testosterone levels, serum levels 30 to 40, free levels about 2 to 4%. Will cover the estrogen deficient symptoms, hot flashes, night sweats, brain fog, memory losses, those kinds of things. In the literature, up to 92%, and I can get you those references if you want them. So
how often do you do the blood test for hormones after starting the BHRD? The hormone replacement treatment.
I do them usually within 3 to 4 months. And then if they're stable, once they're stable, every 6 months to a year.
So what blood level you are shooting for?
For testosterone, 30 to 40. is the sweet spot with free 2 to 4%. We always get a sex hormone binding globulin, and the formula there is you take the total testosterone and divide it by the product of 0.288 times. Hang on, we got somebody coming in. 0.288 times the sex hormone binding globulin. That's your denominator. And your goal is about 1.0 to about 4.0, 5.0 for females. You can do the same thing for guys, but the numbers are a lot different. So that's for testosterone. For estrogen and progesterone, I don't actually look at the normal, the ranges or the normals. I don't really care. What you're looking for is the estrogen to progesterone ratio. And you figure that out by you draw an estrone and an estradiol divided by the progesterone. When they're postmenopausal, it doesn't matter what time of the, when it is. When their patients are still cycling, it's days 19 through 21. And then what you do is you don't need to worry about the units there. So the estrogen progesterone ratio, when it's less than 250, that's our goal. And as it gets higher, the higher it gets, the more of the symptoms you're going to get. So we see our unfortunately, we're so busy now that we've gotten into a routine where we have the patients have their lab work when they come to see us for their first visit. The lab work is already done, and I'll go over it before I see them, usually in the morning, and I can pretty much tell right from there what they're going to tell me as far as what their symptoms are. Once you start recognizing the patterns, it's actually gets fairly easy. But I don't want to interrupt. I'll ask our speaker what his answer is. So, Dr. Nario, take it from there.
Oh, well, yeah, for blood testing, again, that's something, it's almost similar to what you're doing 3 to 4 months and how we do it. And also, but for me, again, I do follow the range. I learned this new method from Dr. Bill. But before I knew about that, the ranges are also something that I follow in relation to the LCMS values, for example, for estrogen and progesterone, but also correlating it to the symptoms of the patient. So those are basically, it's a, I guess, simpler approach for myself. But I do see the method now of Dr. Bill and how he applies it in patients, which actually is a very comprehensive and very intricate approach towards hormones.
Yeah, I mean, it's it's fairly simple. I mean, the calculation is pretty straightforward, and you can follow it along. And as they come, I've been here for 10 years now. You can actually follow along. You follow those ratios, and it tracks really well with the symptoms. And once you get that ratio under 250, their symptoms are gone are over. They just don't have them anymore. I will say I will backtrack a little bit. I do look at estrone levels. When they're greater than 100, we want to intervene. We don't want that. That'll take you down that to that 4 and 16 hydroxy methyl estrone pathways, the cancer pathways. So we want to keep the estrone levels low. Actually, I start getting nervous at 90. So
what do you use for lowering that?
7-keto DHEA. Not DHEA, 7-keto DHEA. I usually start at 25 milligrams, 25 to 50 milligrams at bedtime. And invariably, as long as they take it and they use it, again, a fairly good quality one, you can expect the estrone levels to decrease by half within 4 to 6 weeks. It works really, very quickly. So, and it works quite nicely. So I hope Joel's just asleep and not dead there. Okay, he's catching flies there. He was busy here today at the office, so he was running. I had him running around, so we'll let him take a snooze there. So okay, you have any summary for us, Dr. Nario?
Well, it's just, again, when we talk about estrogens here, it's just not E1, E2, and E3. As you can see, the metabolism of estrogen is very important. And I found that out really when I was starting to work with cancer patients, just because when people think that it's done and over with when you have done chemotherapy, surgery, and even radiation, the underlying reason it's still there And this is the reason why I now really dig deeper to the metabolism, because I need to know what caused that problem at the beginning. So every practitioner needs to understand the basics of this so that they can actually apply this in their own patients and to prevent further recurrence of even future cancers.
Okay, so you have a routine, workup, that you can share with us? Or if
In relation to cancer or just
Yeah,
in general?
well, yeah, or so a postmenopausal person shows up and says, okay, I got hot flashes and night sweats. What do you do?
All right, so it's basically the same process for you. The thing there with the blood testing, and almost everything that you just mentioned are what I discussed. The thing here is that maybe I want to share is how I utilize urine testing and salivary. So for example, for perimenopausal, as we all know, perimenopause is they still having inconsistencies in their menstruation and also the fluctuation of hormones. There's a test called cycle mapping. And then this is something that is done through urine. That's a very long test. It's like a 1 month sampling for the patient, but you will see the actual fluctuations of hormones. And that's when you actually can use that as a guide when you're going to be using your estrogens and your progesterones. When they all, if you see the graph, they all go down. That's when you kind of insert that specific therapy. And then once they're all post-menopausal, now they can just go for the direct use of the simple 30-day urine test. And that's where it's easier to really, I guess, address post-menopausal women, just because they really don't have any hormones being produced anymore. And for the reproductive female, and using urine or saliva, we're always gearing towards to using getting samples from day 19, 20, 21, so that we can know that we're in the luteal phase, and as you will better have a better assessment of the estrogen and progesterone of the patient. And just sharing again, going back to the perimenopausal female, as I always kind of end up seeing all these cycle maps, majority of them would be initially needing progesterone. Just because, as we all know, estrogen dominance is the one that predominates, the picture that predominates perimenopause. And starting them on progesterone would always be something that you're not going to be on the losing end of, just because to negate this specific estrogen dominance that they have. If you don't have a urine test, you can just do a blood test, and you will see there that they will justify your progesterone use already.
And make sure you match it with the symptoms also. So.
Right.
Hey, Dr. Nario, have you heard of Dr. William Donald Kelly, PDS, MS?
No, not really.
This is his book. And this is his Victory Over Cancer book.
Oh.
So he believes in the metabolic system is based on your, what is it? Parasympathetic and your sympathetic systems in relationship to your metabolic syndrome. Okay. And he thinks that some of us are meat eaters, some of us are vegetarian, and some of us are balanced. I haven't talked to you about that yet. Have you worked in?
No, I haven't heard of that.
Yeah, he's got it's pretty huge. It's this whole questionnaire type, system. And he figures out whether you're, meat eater, vegetarian, or balanced. And supposedly he 40,000 patients, he's solved some cancer on them. So I'll get with you and we'll talk about it and we'll see what we can come up with.
Yeah, that'll be great.
Joe,
And then
you can find him and have him on.
His cohort is still alive. Dr. William Kelly, he passed away, possibly under suspicious, blah, blah, blah.
That never stopped us before, did it, John?
No. But his cohort's still alive, and I'll reach out to him and see if we can get him to,
Okay.
He uses enzymes. That's his big deal. That's why I do the Wobazyme with the digestive enzymes with Designs for Health. I always have
lactoferrin.
Yeah, I also throw in the lactoferrin. I kid you not. Lactoferrin, Wobazyme, and digestive enzymes with Designs for Health. Every meal wouldn't go without it, right?
Well, one thing that I can share about cancer again, so this is something that we're doing in the cancer center. is it's something as that's getting started there is it's called the cancer I guess mRNA. I don't want to use the term vaccine, but this is it's called superior oligonucleotide technique, and this is being done in Greece, which is an RGCC company. And we are now running studies on this on our patients over there. And currently the cancer center has been producing almost 30%, 33% of remission for 10 years of cancer diagnoses for a patient. So this is something upcoming, and we're doing in the cancer center. And when Dr. Forsyth Dr. Forsyth presented this study in OMA, the one that you went through, Dr. Bill, and
He presented,
Got it
he
for us,
presented
too.
yeah, he does the grease test.
right.
Yeah.
Yeah,
And this,
if you go on our website, AOSRD, and go look under, I unlocked all of the conferences now, so anybody can look at them. I think 2019 and 2020, Dr. Forsyth gave his results. It might have them in 2022 also. So if anybody wants to look at that, aosrd.org, where you find where all our webinars are, you go to the next column over, it'll say past conferences. And I think there's actually 3 lectures in there from 3 different years there. So so you can get the info yourself. Sorry, I didn't mean to interrupt. Go.
oh no, it's just that I want to tell our I guess our colleagues out there that I think there are only few clinicians who can do it, and Dr. Forsyth is one of them, one of the authorized practitioners who does it here in Nevada. So I'm sure there will be more, but right now it's just intriguing because we're doing all these statistics in relation to this, and 33% is actually pretty impressive for 10-year survival.
Dr. Nario and Stephen Hartman, have you heard of the cancer survival rate with Lactobacillus salivarius?
I never heard of that.
There's some pretty huge results out there that it's pretty powerful in fighting cancer. I'll do my best to do the research, but it looks to be up there with lactoferrin, to be honest.
All right.
Yeah, I believe that. I mean, anything that helps the microbiome, as you know, that's almost 80% of your immune system is right there.
Agree.
Where do you order your lactobacillus salivarius?
Agree.
Where do you order it
He's
from?
asking where to get it, Joe. Do you know?
No, I don't. I'll look into it for sure. I'll follow up with that.
Okay, and you can report back. Okay, anybody else have any comments or questions? Most of the rest of the audience has been pretty quiet. We've been sort of monopolizing the whole talk here. So next week, Dr. Siegel's going to be back. Our integrative veterinarian, and all us human doctors are all kind of jealous of her because she gets to do a lot of the stuff we'd like to do, but can't. I think you're still on, Dr. Siegel. You still here? Maybe not. Okay. So I'll get you the topic. I do have it somewhere, but I don't have it right at my fingertips. So she'll be on next week. The week after right now, I don't have anybody. So if anybody wants to give a talk, we could probably lean on Stephen Hart. I got him the week after on August 18th. I get lean on him just about every week. He gave a great talk last night on oxandrolone, and we'll want to get that one on also.
We can do it.
Okay. So I don't want to work you too hard here, because we got to preserve you for the long haul.
Yeah, no, I'm fine. I got plenty of energy. I can do it.
The rest of us, as you can tell, have our hair is silver. Those of us who still have it.
What about Ashley Madsen? I see she's here. She's been very quiet, but she's got a lot of research that she does as well on estrogen and hormones and stuff.
Get me her. Is she in our database? I'll get.
I know. I invited her tonight. I got her on board here tonight.
Okay, if you send me her email or contact, we'll twist her arm too.
Yeah. I would like to hear her talk about her research.
Okay, that would be great. And welcome thank you for coming. Welcome, Ashley. I see you lurking there. So, okay. Anybody else? Anybody else have any comments, questions? Comments, complaints? We're good at all that good stuff. And if not, John, how's the medical school coming along?
Everything is coming along fabulously. So no problems anywhere. Everything's good.
Okay. And Shell, you got anything for us this week? Shell, anything this week? And how about Dr. Gerber, how about the homeopathic conference that'll be coming up sometime in September?
I'll actually talk, Shell's getting me in contact with, what is it, John? The Azumio water.
Oh, yeah. With Bob Centenary.
Correct.
Right. I have one quick question for Dr. Nario. ReadySorb has a product called ReadySorb Go. It's a phospholipid glutathione in a powder, and you put it in a little jar. So I decided, put a lid on it and succuss it 40 times. It's also homeopathic. Why not?
Yeah, that's actually how we do homeopathic remedies. We succuss it, like we hit it on books most of the time to put inside
Right.
the therapy.
Yeah. So
Yep.
I thought it's very cool. I was playing with it where I had trigeminal, it was neuralgia, right? And then Amlexinox that I got from Dr. Halassa knocked it out. I was like totally amazed. So that's another Zoom conference you might like to go on, is the Chronic Disease Management Group, and I'm sure Dr. Halassa would love to have you.
We gotta rein him in though. We gotta get him to hunker down and just give us the facts and not just drone on for hours at a time. That's the problem.
Well, we have to succuss our prayers.
Dr. Clearfield,
Yes, Dr. Gerber.
Dr. Gerber, I think the homeopathic conference will be a little later than September. I think it'll be a combination of in-person and Zoom. So we're get to work on it.
All right, so let us know if you need some in-person help. Let us know. For better or worse, I have some experience with it now. So
Fantastic. I will appreciate your expertise.
okay, I can be your Tiffany. So Tiffany was Dr. Gerber's right-hand person for a long time. Unfortunately, she succumbed to the wiles of dementia, and she would help me also when we did our 2 live conferences in Reno here earlier on. So
It's nice to visit Tiffany. She's at a memory care center in Western Reno, about 2 blocks from you.
So yeah, I should go see her. Those of you who were at our conference will probably remember her. She was the lady sitting at the front desk, making sure you paid to get in. And she was the one who ran around and got all the little niceties done for us. So I have some experience, Dr. Gerber. If you need some help, we're more than happy to lend a hand.
Thank you.
Okay, because running these conferences is quite, it's like riding herd over. Medical doctor speakers are like prima donnas, and you get 15 of them, for in a 2 or 3 day period. I don't want to go after this one, and this one's was this. One time we had Dr. Royal and Dr. Farshian almost got into a fist fight. So it's quite a challenge though. And I still have I still have our speaker and our amp still around. It's probably as old as we are.
Yeah.
But it still works. So Okay, everybody, anybody else have any comments or questions? Dr. Siegel will be next week. And if anybody has anything they want to present, please let us know. Monday night, Dr. Halassa has his group. They do similar, they always do different things though. And Wednesday night is Dr. Parshian's group is the American Academy of Stem Cell Physicians. They cover a lot of the things that we cover also. I'm actually a pretty prominent speaker with them. I did part 1. I'm going to do 4 parts, one a month on traumatic brain injury. So I already did part 1. They have you know, but they do a little bit more of the regenerative medicine things. So so if you want those, you know, let me know, and I'll get you their contact information. It's also free. So with that, I'm going to say, you know, anybody else, Dr. Nario, thank you so much. That was really terrific.
Thank you.
Right. And anybody else, any comments, questions, John? What else
Everything's
is
good.
going on?
Everything's good.
The AOA's House of Delegates was 2 weeks ago, and I've heard nothing. I tried to just look at the resolutions, and you need a password. They won't even let me look see what they did this time. So so be it. We'll live without it, right? So
Yep.
okay. All right, everybody. Good night. We'll have the video on as soon as I have it rendered. And again, aosrd.org/webinars. We have all our videos. We have a lot of the slideshows that go with it. And we also sometimes have the transcripts. So you can always get everything there if you missed it. So we'll see you next week, same time, same station. You know, comments, questions, let me know. And I'm going to say good night. Have a great night. Thank you. Thank you all so much for being here.
Thanks, Dr. Nario.
Thank you, Dr.
Thank you.
Nario. That was great. Okay. I'll talk to you soon. Okay.
Welcome.
Thank you.